And good morning, good afternoon, and good evening, wherever you are. My name is Craig McClure, and I lead CHI's viral hepatitis program. I'd like to welcome you all and thank you for taking the time out of your day to participate in this webinar, launching CHI's second edition of its Hepatitis C market report, this time with preliminary market insights into the hepatitis B market. I want to note up front that, as with everything CHI does, we produced this report thanks to the many partners who engaged with us. First and foremost, ministries of health in the countries we support, suppliers and distributors, civil society, WHO, and other UN organizations. I want to especially thank the UK government's Foreign, Commonwealth and Development Office, who provide ongoing support to CHI's global and in-country work, including for the development of this report. Finally, I want to thank the many members of country and global CHI teams who contributed their expertise, time, and hard work to pulling this report together, with special thanks to Ritiban Gautam from our global markets team for coordinating the overall project. Just a few logistics. Feel free to type in your question using the Q&A function. Sean Regan, Claire Watkins, and Magdalena Witchy will respond in real time if possible. There will also be a session towards the end of the webinar for questions and answers directly. And if we're not able to answer any questions during the webinar itself, we will follow up individually with you afterwards. Please note that the chat function has been disabled for this webinar. Next slide, please. Here you have the agenda for the next hour and a half. Following my introduction, Dr. David Rippin, CHI's Chief Science Officer and Executive Vice President of Infectious Diseases, will introduce Dr. Meg Doherty of the WHO, who will be followed by Emi Okamoto, taking us through the diagnostics highlights, Ritiban Gautam, who will cover treatment highlights, Dr. Christian Reimers, who will cover issues related to the emerging pediatrics market, followed by Oriel Fernandez, who will cover some preliminary hepatitis B insights. And last, but certainly not least, we will focus on two country examples, one from Nigeria to be presented by our own Chukwemeka Agwocha, and then from Indonesia to be presented by Caroline Thomas from our Indonesian civil society partner, Yayasan Peduli Hatta Bangsa, excuse me. And then we'll round off with the Q&A. Next slide, please. There are a number of new topics that are covered in this report, including the impact of COVID-19 on the hepatitis C market and programs throughout the world, products and pricing for diagnostics used for liver staging to determine the most appropriate length of treatment for people living with hepatitis C, the use of dried samples for hepatitis C viral load testing, emerging markets for the HCV retreatment and for pediatrics, including the first addressable pediatrics market sizing estimates, and as mentioned earlier, preliminary information on the Hep B market. Next slide, please. The report targets a broad range of stakeholders that we hope will use it to leverage better pricing and wider access to quality commodities used towards achieving the 2016 World Health Assembly endorsed commitment to elimination of viral hepatitis as a public health threat by 2020. First and foremost, country governments and health programs in low and middle income countries who can identify in the report opportunities to optimize pricing and volumes based on market trends. Second, donors and investors who can use the report to identify current gaps in the market and the potential for high value for money investments. Third, civil society, UN, and other international technical support organizations, as well as researchers who can use the report to advocate for and support implementation of solutions that may address current market inefficiencies. And fourth, manufacturers and distributors who may choose to use the report to inform their market development strategies based on volumes, pricing trends, and in-country markups across different geographies. Next slide, please. Top line message. HCV care, despite a multitude of challenges, has gained momentum over the past few years. WHO's progress report released in June of this year showed that the number of people living with chronic Hep C infection globally that cumulatively were treated to cure hepatitis C increased from 1 million in 2016 to 9.4 million by the end of 2019. Furthermore, pricing for WHO pre-qualified diagnostic and treatment commodities has hit a new bottom line. Rwanda, a country that in 2018 committed to elimination of Hep C within 5 years, is now paying for a full hepatitis C cure commodity package of 1 rapid diagnostic test to confirm exposure, a viral load test to confirm chronic infection, 12 weeks of sofosbuvir declatosphere, and a final viral load to confirm cure for less than US $80 per person. A phenomenal achievement, especially when you consider that the drugs alone cost approximately $100,000 per person when they first hit high-income markets only 7 years ago. Next slide, please. I would be remiss, of course, were I not to mention the significant impact the COVID-19 pandemic has had on low and middle income country programs and on the market. Case finding activities and care seeking for many diseases, including hepatitis C, decreased across most low and middle income countries as they responded to limit the spread and impact of COVID-19. And they continue to be impacted by recurring surges or waves, particularly as the world grapples with inequitable distribution of vaccines. But creative approaches have been taken by many countries, including the adoption of alternative ways of service delivery, such as multi-month dispensing of drugs, online meetings, telemedicine, and virtual trainings. Suppliers have also mitigated the challenges of high lead times and prices of key starting materials imported from China by exploring alternate procurement options. Still, it goes without saying that we would all benefit from emerging from this pandemic, and the sooner, the better. Next slide, please. There are 6 areas where countries and the broader hepatitis community can focus to improve the efficiencies of the market to make HCV care more accessible, especially during the pandemic. To leverage volume and forecast-based pricing, access international procurement mechanism negotiated terms and pricing where national procurement processes are either not feasible or cost-effective. Ensure price transparency and reduce internal markups, such as excessive distributor margins or other costs. Facilitate expedited in-country registrations of both diagnostics and drugs, and integrate testing across diseases where it makes sense. Finally, the use of public-private partnerships in settings where public programs are underfunded or still developing can reduce out-of-pocket expenses through pooled procurement. Next slide, please. I'd like to now introduce Dr. David Rippin, Chief Science Officer and Executive Vice President of Infectious Diseases at CHI. Dave, over to you.
Thank you, Craig. I'm thrilled to open today's external launch of CHI's second edition of the Hepatitis C market report, this time for the first time also including insights into the hepatitis B commodity markets. I'm also absolutely thrilled to introduce my good friend and a real leader in the fight against hepatitis, Dr. Meg Doherty. Meg is the director of HIV, viral hepatitis, and STIs at the World Health Organization, a position which she assumed in 2019. From 2012 to 2019, Meg provided the overall coordination of HIV treatment and care at WHO. Meg received her MD from Harvard Medical School and MPH and PhD in infectious disease epidemiology from Johns Hopkins. WHO continues to be CHI's most important partner in its work supporting global and country-led efforts to eliminate viral hepatitis. And we are thrilled that Meg, you are willing to offer your time and energy to today's launch of the Market Intelligence Report. And Meg, the next 15 minutes are yours.
Well, thank you very much, Dave. And that was really quite a very nice introduction. I really appreciate it. And again, also CHI, especially in this, in both the public health approach for HIV and in hepatitis, we have been great partners together. And so I really respect the fact that you're asking us to help open and launch this event and this report. I just want to check to ensure that you're seeing a full screen version of the slides or just a partial screen.
We see the full screen.
Okay, perfect. So thank you very much. And again, I was asked to speak about how this important report sort of fits into the work that we're doing at WHO. And I think there's been such a great history of the market shaping and the market intelligence report, as well as now looking into where we're going with hepatitis B, how it can really help both our development of new strategies, development of new guidelines, but also ensure that countries know what other countries are getting in terms of prices, access, and certainly information is power in this field of hepatitis. And as many people have heard me say before, I feel like when we set out to end AIDS as a public health threat by 2030, eliminate viral hepatitis as a public health threat, I have the greatest hopes in around hepatitis, because not only did you hear from Craig about how quickly the prices have come down, the all-in prices, but there's really, although it's a large section of the world that needs to be tested and to find the missing cases and the missing millions, it's something that if countries put their mind to it, they've been very successful at. For example, Rwanda and many other countries now on the cusp of wanting to pilot for the elimination criteria put out by WHO this year. So let me just take you through, you heard already from Dr. McClure that under our previous and our current global health sector strategies that run to the end of 2021, we have very ambitious targets towards eliminating viral hepatitis as a major public health threat and reducing both deaths and infections by 65 and 90% respectively. And I think we have a long way to go to make those targets, as we'll see. This year, in preparation for developing new global health sector strategies, we put out a report that was looking at where are we in terms of numbers of new infections, prevalence, burden. And what we'll note is that the HCV prevalence is now noted to be at nearly 60 million. HBV prevalence around 296 million, and HBV prevalence under 5 years, 6.4 million across the globe. And in the report, you can see that the distribution is varied, and there are certain parts of the world where the burden is greatest, and in many places where low and middle income countries have had less access to both the diagnostics and the treatment is where the burden is greatest. We also know that we are starting to see the consequence of infections from hepatitis B and C, and we're able to now start to monitor the death associated to hepatocellular carcinoma, now noted to be about approximately 500,000 for this past year in 2020. So this is important, that not only can we measure new infections, we can measure death, and we can measure the prevalence, which is a lot more than we could measure approximately 5 years ago. So not only have the prices of drugs and access and diagnostics come down, we've seen also improvement in the data that is available. And that's so important to help guide us as we move forward. This report also notes that we have 3 million new combined Hep B and Hep C infections, 1.1 combined Hep C and Hep B deaths. Among those 1.1 million are the 500,000 related to hepatocellular carcinoma. As you heard, we've had a great increase in the number of people accessing hepatitis C treatment, up from approximately 1 million to 9.4 million at our baseline at the start of the strategies. And we've achieved one global one SDG goal, which was achieving less than 1% prevalence of under 5 hepatitis B prevalence. But we still have in hepatitis B a lot of work to do where the majority of new infections are occurring, where we have not fully achieved the hepatitis B SDG goal. So it's nice to know this new this new study will, this new report will be able to focus on that. Next, I wanted to show you also the data around this, what we have in terms of finding and putting people onto treatment, or our cascade, as one would say. Only 10% of the 296 million people with chronic Hep B were diagnosed in 2019. And this varies, as you can see, by region. So we have a lot of work to do around hepatitis B in terms of diagnostics. And 21% of the 58 million for chronic Hep C. So again, we have certain regions who are doing really well, but those that are in the greatest need, the African region in terms of low and middle income countries, are really falling behind. And the examples that we've seen from Rwanda will be very important as we move forward. So are we on track to make our ambitious targets? I think one could say our ambitious targets at 2020 were within scope. We were able to actually meet these targets, but they were relative reductions in not absolute numbers. We had a very unclear baseline and a very wide baseline in terms of new infections, and had difficulty being able to measure deaths. So I think as we move forward in the next 5 years and the next 9 years, we will have a harder time, but we can make these targets, I believe, as long as we can continue to increase access and increase government endorsement and ability, to be, I just want to ensure, are you seeing my slides? It feels like something is said it's paused.
Yes, we are, Meg. We were not for a while. I think
Okay.
you have control over advancing.
All right. So I just want to make sure, which one are you on? Are you seeing the viral hepatitis targets we're on track slides?
Yes, we are. Yes.
All right. And as I move here, COVID disruptions or not?
Yes. All
Okay,
good.
super. So good. I got an emergency message saying everything is paused. Okay. And as we heard as well from Craig earlier, we know, and we've been monitoring, what are the disruptions that have occurred for health services. And in particular, we know a lot about HIV and TB because we have so many data systems out there. But for hepatitis B and C diagnosis and treatment, we know they've been infected, but we don't have as much granular information. And what we don't know is how far that has put back programs that we're going to embark on: hepatitis elimination, hepatitis programming, Hep B birth dose vaccine for infants. We will not see that, I think, for another year or two. And certainly we know there's been some delays. So on to what has WHO put out this year in terms of guidance and guidelines. We have put out in June this year, and hopefully you've seen it, interim guidance on the country validation of viral hepatitis elimination. And this sets out a set of targets and also criteria, both for incidence and mortality and for programmatic service delivery, by which countries can measure whether or not they're reaching or getting close to elimination. And I think we now know that we have 6 countries who have signed up to pilot these interim criteria and targets. And I believe this will mean that over the next several years, we'll have some countries coming forward with clearly showing that they've made huge impact in reducing new infections and getting closer to elimination. The next piece that was asked of us is, how are we starting to take all of the work that's come together and consolidate and what's next on the horizon for guidelines? Because I think what you see out of this new report is a forebear for, or is looking forward to some of the new recommendations that we're going to be thinking about and having guideline groups over the next year and a half. One thing to note is in the WHO, many of our guidelines have been consolidated so that for the end users, we hope it will be a one-stop shop where they can get as much information as possible. Hepatitis has come out with regularly different guidelines on Hep C treatment, on Hep B and C diagnostics, on Hep B treatment, on the elimination of mother-to-child transmission of Hep B, and most recently in July on hepatitis C self-testing, as well as what we call the Orange Book, which are the criteria for triple elimination, of which hepatitis B is one. So in 2022, we aim to consolidate this so that there's coherence between our recommendations, as well as a one-stop place to find all the new recs. This slide just outlines in the last 5 years of the guidelines how much has come together where there wasn't before. And I think that the biggest thing I could say is that we've moved to a treat-all, a simplified, optimized approach for hepatitis C. And it feels like we're on the cusp of needing to be able to do something similar for hepatitis B, as well as ensuring that we're starting to strengthen our strategic information at country level so that we can actually have good data at country level in their health systems, in their EMRs or electronic medical records that are helping each country determine what is the next step as they move forward towards elimination. So this is a long list coming up here next, but it really shows how WHO wants to take the new evidence that's available and also look at what's feasible, what civil society is asking for and what is acceptable so that we can start to deliver important programs. So for hepatitis C treatment, there is right now under development and under discussion, can we do rapid initiation of hepatitis C treatment after a confirmed hepatitis C case? I can't tell you what the outcomes are, but these are really important for those who are high risk or key populations that they have access to early treatment, much in the lines of HIV test and treat or treat all with rapid initiation. We'll also be looking in this fall at simplified service delivery approaches, looking at both the pediatric and the adult DAAs so that we can have this simplified and to the best of the ability to optimize the market so that both children and adults can use the same therapies, different doses. But in HIV, this has been key to be able to drive prices down, simplify so that nurses can deliver, and really moving our services out from the specialized into the place where public health approach can actually be implemented. And looking at retreatment approaches and regimens. In terms of testing, you heard about the HCV self-testing recommendation, which we think is going to go very far for helping us to find those missing millions. But also, when do we need to repeat testing about those who are very increased risk or high incidence? the using a point of care viral load. We've seen with HIV and early infant diagnosis that has revolutionized the ability to start treatment early, to reduce turnaround time, as well as drug blood spots, which you have mentioned in your report. And then towards next year, early in next year, we'll be looking for hepatitis B as well, simplifying the service delivery approaches, expanding criteria for treatment. So how do we make this easier? How can we reduce the number of different diagnostics that need to be done for treatment? And also looking at what might be long-term treatment availability, either TAF, tenofovir, and really working on those prices. And all I could say with that is after that, we'll be pulling that all together into a single document so that you have it consolidated. This is the recommendation around hepatitis C self-testing. It should be offered as an additional approach to hep C testing as a strong recommendation with moderate quality evidence. And it's really about linkage and adapting the service context and including communities and ensuring those who have been left behind can really be identified. And here I'll leave this to you to be shared, but there's a number of resources and alongside multiple partners, including CHI as well as FIND, there's some excellent videos on how the community is taking this forward. I want to circle back to why is it so important that this report, and I think WHO has put out annually an accelerating access report to hep C diagnostics and treatment, and they serve in some ways as sister documents. But I think for us, what's quite important is to see that we're moving towards a public health approach, that we're simplifying and knowing what the market is and pushing the market, they go hand in hand. And I think it's also about identifying the financing and procurement options that need to be overtly available so that programs can move this forward. In our report, we talk about the quality of the drugs and the DAAs in particular, and this came out in 2020. And at that time, we really needed to have I guess, greater emphasis on rapid diagnostic tests as we go forward, because now we have 4 molecular HCV tests that are pre-qualified in 8 serologies. And we don't have pre-qualified fixed dose combinations, something that was really quite important for HIV to ensure that fixed dose combinations pre-qualified and available in for the best treatments. We also need to have a, yes?
Could I just prompt you to advance the slides and also to wrap up in a couple of minutes? Sorry to interrupt.
Sure.
Thank you.
Thank you very much. We have key enablers of the DAAs, and affordability is important for the diagnostics. What I'd like to say in closing, as we're working towards an updated set of strategies, and we're almost there. We'll be presenting it to our executive board in January 2022. And I think what we'll see here is as we move forward, we want to be ensuring that we have people-centeredness, optimized systems, generating data, engaging communities, so that as we move forward, we can really reach this and eliminating of hepatitis. So with that, I just want to say thank you very much. We are very happy to have this extra report out there, and we're seeing that there's an opportunity now to support the countries and to speed up the hepatitis B programs as we start to see what the market looks like for the hepatitis B, both drugs and diagnostics as we move forward, as well as for elimination of mother-to-child transmission and pediatric treatment of both of these viral hepatitis. So I appreciate the opportunity. Thank you. And apologies for the difficulty with the slides.
Thank you so much, Meg. There's a huge amount of work going on at WHO at the moment in guidelines development, evidence generation, strategic information, and of course the critical role that you play in advocacy. I hope that you'll be able to stay to the end for the question and answers. And thanks again so much for joining us today. I'd like to turn to Emi Okamoto now to cover some of the HCV diagnostic highlights. Over to you.
Great, thank you, Craig. So we'll look first at HCV, the diagnostic highlights. Next slide, please. So as we just heard, there's significant room for growth in the diagnostic market. The Global Progress Report shows 58 million people living with HCV worldwide. And as Dr. Doherty said, there's some variation among regions. So in the Southeast Asia region and Africa region, over 90% remain undiagnosed. This untapped market is available by reducing barriers to access through increasing awareness and screening, and donor and domestic financing towards testing and treatment. So this report utilizes a public database of approvals, information from in-country sources on pricing paid by public programs, and access deal pricing published or discussed with suppliers. A public database on global diagnostic approvals, pricing, and volumes could provide more transparency and help predict some of these market trends. So first we'll look at screening, which is done with an HCV antibody test. There are many quality assured tests already available. We'll see in Exhibit 3 that 10 have WHO pre-qualification. 6 of these are lab-based HCV immunoassays, whereas 4 are rapid diagnostic tests, or RDTs. Quality assured RDTs have programmatic benefits over the lab-based immunoassays. One is enabling decentralization of screening, allowing the test to be run at the level of health facility or even in the community at the level of the patient. Second is mitigating challenges of sample transportation and collection. If the test is done at the point of the patient, there's no need for phlebotomy or for sample transport of plasma samples. And thirdly, there'll be faster turnaround time in results, as these tests can be done within 30 minutes. Self-testing can be an additional approach to screening, as we just heard from the WHO. However, no products have WHO pre-qualification yet for use in self-testing. Now, when we think about the pricing of screening tests, many countries are accessing RDTs at lower than $1, which sets a benchmark for other programs to target. And this is similar to other disease areas where rapid diagnostic tests often cost below $1. Georgia has the lowest price at 12 cents for a CE mark test, and we see Egypt has the lowest price for WHO pre-qualified RDT at 58 cents. Several countries are accessing prices higher at around $1 to $2. Next, we'll move on to talk about liver staging. So common blood tests that are routinely available and affordable already in LMICs can be used for fibrosis assessment. WHO guidelines recommend assessment of hepatic fibrosis or cirrhosis to determine the DAA treatment duration length. Transient elastography, which is a non-invasive ultrasound-based technology, is often unavailable or unaffordable in LMICs. On MapCrowd, we can see that transient elastography costs between $15 to $100 or more in many countries. So liver health is frequently assessed using common blood chemistry tests like alanine transaminase or aspartate transaminase in combination with a hematology for platelet count. These can calculate the APRI or fibrosis 4 score and indicate the level of fibrosis or cirrhosis present. We'll see in Exhibit 7 the cost of these common tests in 3 countries. They cost around $1 to $4 per test, and the total screening can be done at around $5. Next, thinking about viral load. Diagnostic platforms commonly used for HCV viral load have a large global footprint, in part due to HIV and tuberculosis programs. We see in Exhibit 4 that there are multiple programs, and this multiple platforms, and this is non-exhaustive, that are able to run HCV and HBV viral load, in addition to other common diseases like HIV, HPV, and SARS-CoV-2. There are 3 additions to the WHO pre-qualification list since our last market report. First is the Roche Cobas HCV viral load test on the Cobas 68-8800 systems. Second is the Abbott real-time HCV run on the M2000, which can now be run with a dried blood spot sample. And this represents the first viral load assay with pre-qualification for use in a dried sample. And lastly is the GeneDrive HCV ID kit, which offers another option for point-of-care technology. So for viral load, while global pricing exists, many programs are still paying very high prices for their tests. In the orange bar, we have a range of the global access pricing available, and we'll see that Rwanda serves as a valuable benchmark, accessing the test at $9.30. Multiple other countries are accessing the test at around $20 to $30, and then there are several countries on the right which are paying 4 to 9 times the highest pricing available on the global access agreements. So this represents an opportunity to be able to make this more affordable for countries. So for viral load, leveraging suppliers' global access agreements can provide benefits to programs. Suppliers offer different terms, which are variably inclusive of different cost components. Exhibit 9 of our market report goes through this in detail, and you can see a snapshot of part of the exhibit here. They include different terms like instrument placement, service and maintenance, and Incoterm options. Be aware that this global pricing may be associated with an annual test volume commitment, which could be applicable across different disease assays, including HIV and TB, which would allow for pooled procurement and using other volumes to access these prices. So finally, understanding the net individual costs of these differing test strategy can enable the optimization of the diagnostic cascade. Be aware that multiple cost components add to the final price paid. Visibility into this price breakdown can help with negotiations, comparing costs and services between suppliers, identifying opportunity for cost reduction, and assessing budget impact. In Exhibit 12 and 13 on the right, we see pricing from an anonymous country when looking at global access pricing from a Roche and a Cepheid assay. Both have about 30% markup due to different logistics, shipping, and handling fees. We'll note that beyond looking at just the price, there are other considerations. For example, that Cepheid can be brought to the point of care. So open communication with suppliers, distributors, and import agencies can help achieve this price visibility. Again, beyond just the price, other implementation factors should be considered, including sample collection, sample transport, and platform availability. Our report discusses 3 topics more in depth. The first is rapid diagnostic tests versus lab-based immunoassays. Seeing that beyond the benefits of rapid diagnostic tests, there may be cost implications which favor rapid diagnostic tests due to the lack of sample transport needed. Second is point of care versus central platforms for viral load, and enabling the technologies to be decentralized to the level of patient through point of care at the level of facility or near point of care through a hub and spoke model. For countries using central platforms, they may consider using dried samples like dried blood spot versus plasma samples, as there may be benefits to both the program and the costs of using dried samples. This has been done for years with HIV to decentralize access to viral load and could be something that's used by viral hepatitis programs. So when looking at both the cost components and other implementation factors, we hope that countries and governments can use this report to help optimize their diagnostics cascade and allow more people in the population to access hepatitis screening and treatment. And with this, I'll pass back to Craig.
Well, thanks so much, Emmy. I mean, you covered a huge amount of shifts in the diagnostic space. I think the expansion of WHO pre-qualified products for rapid screening and viral load, the potential for dried blood spots to speed up the delivery of viral load results, the promise of HCV self-testing, and of course, the potential for countries to leverage global access pricing by pooling procurement across disease areas using the same diagnostic platforms. Thank you so much. I'd like to turn to Richiban Gautam now to cover some of the HCV treatment highlights in the report.
Thanks, Craig. I'll now go over some of the key highlights of HCV treatment market covered in the report. Let me start with supplier landscape of WHO pre-qualified direct acting antivirals, which has expanded considerably over the last few years. Most WHO recommended DA regimens now have at least one WHO pre-qualified product available. There are now 5 generic sofosbuvir product and 4 generic daclatasvir product with WHO pre-qualification. Lotus Labs daclatasvir has been the recent addition to this list in 2020. Besides the fixed dose combinations of sofosbuvir, daclatasvir, and sofosbuvir velpatasvir, respectively, also now have a generic product that is WHO pre-qualified. Moving over to volume trends, we have primarily used India export database and medicine patent pools reported daclatasvir sales to analyze volume trends. While India export database doesn't capture generics and generics manufactured outside India or sales by originators such as Gilead, it does provide a good picture of the trend as most of the generic suppliers are based out of India. In recent years, there has been a scale up in DA procurement. Generic daclatasvir sale reached a milestone of 3 million packs by end of the last year. Most of this scale up in 2018 was driven by India, Pakistan, and Egypt. However, in the last couple of years, there has been a shift in this trend. Rwanda, Ukraine, and Uzbekistan have also scaled up HCV care. While these countries have scaled up HCV care, as mentioned previously even by Meg, only 13% of chronic HCV infections have been treated by 2019 globally. As per estimate, more than 50 million patients remain untreated, which indeed is a significant opportunity for program to scale more rapidly. Lastly, as we see here, there is a preference for pan-genotypic drugs when it comes to procurement. Sofosbuvir paired with daclatasvir remains the most widely used HCV regimen across low and middle income countries. In terms of price trends, increase in DA's uptake has been driven by a significant price reduction over the last few years. There has been price decline for all the DAs. If you see here, sofosbuvir and daclatasvir course used to cost more than $300 on an average in 2016. It now costs somewhere between $70 to $90. While yes, the price reduction has slowed down over the last couple of years, we do expect further reduction to happen in these countries based on and to be driven by these 2 factors. First, supply chain optimization to reduce some of these in-country price markups. And second is centralized procurement by countries to leverage volume-based pricing. Benchmark prices have declined significantly over the last few years. 12 weeks of sofosbuvir and daclatasvir costs $75 to programs through Global Fund pool procurement mechanism. While there are countries paying lower than $75 at one end of the spectrum, access remains uneven, with many countries paying more than $200 for the treatment course. Essentially, there is a lot of variances in country prices, and there is no standardized global price that countries are accessing yet. Rwanda, Egypt, India, and Pakistan have benefited from rapid scale-up of HCV program and are accessing low DA prices. The biggest highlight over the last year in terms of price reduction has been from Indonesia, as they secured 85% reduction in soft and daclatasvir price over the last year. Carolyn Thomas would talk more about it later in the webinar. In general, countries do benefit from lower pricing by planning procurement and ordering DAs in optimal quantities. As you can see from the graph on the slide, we have looked at different ranges of order placed on x-axis with price on the y-axis. And overall, as the order size increases, suppliers do offer a lower price. From supplier point of view, large orders allow them to plan manufacturing more efficiently, which in turn can lead to lower prices for buyers. While programs can access lower pricing by not spreading out procurement and ordering in bulk. In this way, they would be able to subsequently buy more treatment course with the same budget. We have also seen that one of the factors that in-country price is high in few places is due to supply chain associated markups or distributor margins in those countries. On this chart here in the slide, we have tried to highlight some examples of these high markups. The high markups typically vary across country and can be as high as 3 to 6 times of the ex-works price. Now, programs with high in-country markups can aim to reduce prices by identifying these contributing factors and optimizing them. Moving on to the retreatment market. Though the cure rate with first-line DA therapy is approximately 95%, and number of people who fail treatment is small, as programs are scaling up, that a small but significant proportion who fail treatment do need other options. And subsequently, as countries which are scaling up HCV care, they're also looking at retreatment of patients who didn't achieve SVR after 12 weeks of treatment. WHO guidelines currently recommend using soft well walks for patients who have failed initial treatment or extending the initial DA therapy to 16 or 24 weeks while focusing on adherence. However, the challenge is that currently soft well walks is only available from the originator Gilead with no global access pricing for low middle income countries. A 24-week course of ribavirin with either soft daclatasvir, soft ledipasvir, or soft velpatasvir are the most commonly used second-line therapy regimen across low middle income countries as of now. Assessment of some of these programs are under progress for evidence generations and guidelines consideration. But in terms of the supply challenges, while DAAs have WHO pre-qualified generic products available, there are no WHO pre-qualified suppliers for ribavirin. Only 2 generics which have US FDA approval are supplying in low middle income countries. In short, the retreatment market is small and limited quality approved supply does pose an access risk for the HCV retreatment programs. Better quantification of patients needing retreatment, transparency into procurement plans, and pooling of demand across programs could help suppliers plan production capacity, leading to lower lead times and prices for these products. With that, I'll now hand it back over to you, Craig, to keep us moving forward. Thank you.
Thanks so much, Richiban. A lot of issues again covered there, but I think some of the top line messages that we have a pretty healthy supply in the market of multiple pre-qualified generic versions of sofosbuvir, declatosphere, and velpatasvir products. That even though the volumes have been driven primarily by Egypt, India, and Pakistan, we're seeing numerous other countries where volumes are increasing as countries scale up. And I think an important figure to notice that over 70% of volumes of DAAs are for sofosbuvir and declatosphere, so that remains the preferred option. And then interesting points, of course, around the potential for accessing further reductions in prices, really depending on pooled procurement centrally in countries of volumes and getting some of those in-country markups, as you call them, down. And we'll hear more, as you said, later from Caroline about how efforts succeeded in Indonesia to do just that and secure 85% reduction in pricing of sofosbuvir and declatosphere. I'd like to turn now to Christian Reimers, our senior clinical advisor, to talk a little bit about the emerging HCV pediatrics market.
Thank you so much, Craig. If we could go to the next slide. So I've got a lot to summarize in just 2 slides. It's been a very active area in terms of HCV therapeutics. But before I get to the content, I want to just cover a little bit of background related to hepatitis C in children. So many of you are probably familiar with the way HIV can devastate newborns and infants. And as any pediatrician will tell you, children are not just small adults. The pathophysiology, the aggressiveness with which HIV can cause disease in young people and infants and children is undeniable. After about a 30% vertical transmission rate, in the absence of prevention of mother-to-child transmission, HIV is incredibly aggressive, and it's fatal in about 50% of cases by the age of 2. Now, hepatitis C is really completely different than that situation. So we need to adjust our thinking about HCV therapeutics when we're talking about young people, newborns, and infants. The vertical transmission rate for hepatitis C is closer to 5%, as high as 10% in HIV hepatitis C co-infected situations. And even those who are thought to be infected at birth, about 25 to 40% of them will spontaneously clear their hepatitis C infection early on, and probably another 10% will clear before adulthood. So we definitely need to adjust our thinking in terms of going after HCV therapeutics aggressively in the newborn and young adult period. In terms of ongoing studies of what happens to children who have HCV, the studies are quite limited, but there have been several cohort studies showing relative stability of fibrosis on liver biopsy up to 3 decades through follow-up. Now, this is not to say that children are not important and that treating children with hepatitis C is not important. On the contrary, there's data from Egypt showing that the emotional and mental health and cognitive effects of hepatitis C probably go under-recognized. And if we are to think about elimination as a holistic goal and a holistic process, of course, we need to think about all individuals and not just adults. So with that as background, hopefully I'll go through why we need to take a measured and circumspect approach to age bands and how we address age bands in HCV therapeutics. Now, as Meg showed you, the most recent treatment guidelines for hepatitis C in 2018 did recommend a universal adult treatment approach. However, it was recommended to defer treatment for those that were less than age 12. And we are anticipating in the coming months updated guidance which will address HCV treatment into much lower age bands. In terms of other updates, the Global Accelerator for Pediatric Formulations, or GAP-F, has been meeting over the last several years, and the consensus is really that the regimens available need to align with those regimens that are available for adults, so that we can have really harmonization of the 3 pangenotypic DAA regimens across different age bands. As I mentioned, we do expect upcoming guidelines to include all currently recommended pangenotypic DAA regimens amongst the lower age bands. Now, as I mentioned, children are not just small adults, and so dosing is a really important consideration here. In the US, Gilead and AbbVie, the makers of the 2 main innovator products, have achieved FDA approval in Q2 of 2021 for the use of sofosbuvir velpatasvir and glecaprevir pibrentasvir in various pediatric formulations among children all the way down to the age of 3 years. As you've heard several times, however, 70% of the procurement of DAAs globally is actually the regimen of sofosbuvir decladisvir. So it is really critical to address how to use this regimen in lower age bands. Thankfully, with decladisvir, due to a drug interaction with HIV protease inhibitors, there is a 30 milligram dose that has been available, and that should provide appropriate exposure amongst younger children. In the upcoming pediatric guidelines, I anticipate that we'll be seeing more data about that 30 milligram dose. There are also several pre-qualified decladisvir generic manufactured tablets already available. Now, importantly, there is not yet an available generic product of sofosbuvir 200 milligrams that would be needed to pair with decladisvir to customize that regimen down to lower age bands. However, there are dossiers for pediatric regimens of sofosbuvir singles, decladisvir singles, and then sofosbuvir decladisvir, sofosbuvir velpatasvir, and glecaprevir pibrentasvir that have been submitted to the WHO expert committee for review, requesting inclusion on the essential medicines list. Next slide, please. So on this slide, you see data that is originally derived from a modeling study published in The Lancet And then also further work done by Chai in this version of the report to quantify the addressable market of children. Now, as I mentioned, earlier WHO guideline versions, the one in 2018, really did recommend treatment for age 12 and up. And as you can see in this pie chart here, of the more than 3 million children that are estimated to have hepatitis C, over 50% of them actually can be treated with adult formulations. You can see the 12 to 18 age band comprises 56% of this population. And transmission actually may be different in these different age bands as well, as adolescents are much more likely to be infected through the sharing of unclean needles or through iatrogenic spread. When we get to lower age bands, the lightest blue, as you can see, age 0 to 2, comprises only 7% of this more than 3 million. And as I mentioned earlier, most pediatric hepatitis experts really recommend a watch and wait approach because of the high percentage of children that will eventually clear that hepatitis C infection. So really the addressable market is comprised of those two middle bands, age 3 to 6 and age 7 to 11, because those that are less than age 3 are likely to be excluded. And as I mentioned, those above age 12 can be treated with adult formulations. So in this version of the market report, Chai quantifies this as roughly 1 million individuals, as you can see, broken down on the right here, with 13% of the 3 to 6 age band and 19% of the 7 to 11 age band. Furthermore, what is the addressable market? Well, of course, countries with very immature hepatitis treatment programs are unlikely to be screening and identifying large numbers of children. So rather, turning to countries that have more mature and more developed programs will define more of the addressable market. In the bottom there, you can see this is defined as children requiring pediatric dosage across 7 countries that do have already robust adult programs, such as Rwanda, Egypt, India, Mongolia, Pakistan, Georgia, and Ukraine. And using this logic, we can say that about 500,000 pediatric patients will need treatment with pediatric formulations going forward. So I'll stop there and hand back to Craig.
Thanks so much, Christian. I think the message there is we'd all like to see the children, at least 3 to 11-year-olds throughout the world with Hep C, chronic Hep C, have access to treatment. And that would be over 1 million children. But at least to begin with, to start with the countries with robust adult programs, which we estimated to be about 500,000 children, 3 to 11 years in those countries, and to have available the guidance and the pediatric dosage formulation of generically of sofosbuvir to pair with the 30 milligram declotesvir. So thank you so much. We're pretty much on time. We're about 2 minutes behind. So I'm going to turn straight to Oriel now for some HBV preliminary market insights. Oriel?
Thanks, Craig. Hello, everyone. I'll speak briefly to some preliminary insights on the HBV market, which, as Craig mentioned earlier, is a new topic area covered in this report. Could I have the next slide? That's great. So in terms of where we stand on progress towards addressing hepatitis B burden, the recent WHO report covering global progress on HIV, viral hepatitis, and STIs that Dr. Doherty referenced highlighted a very important success story for HBV. The 2020 global target of the Sustainable Development Goals and the Global Health Sector Strategy to reduce hepatitis B surface antigen prevalence to less than 1% among children younger than 5 years has been met. And this is largely because of the availability and scale up of highly effective HBV vaccinations. Despite this, the global burden on HBV remains high. As of 2019, there were 296 million people living with chronic HBV globally, and an estimated 820,000 deaths from HBV, along with 1.5 million new HBV infections per year. Despite the availability of effective testing and treatment that overlap with those used for HIV management, few lower and middle income countries have public programs for HBV testing and treatment. This is evident from the low coverage of HBV prevention, testing, and treatment interventions that you can see on the right-hand side of the slide, highlighting that there is significant room for growth in the HBV diagnostics and treatment market. Just to call this out, only 10% or 30.4 million people estimated to be infected with HPV knew their status in 2019, and only 22%, approximately 6.6 million of people diagnosed, were on treatment worldwide. So many factors contribute to the significant gap in access to HPV services, including a complex diagnostic algorithm that makes it difficult to implement a public health approach to HPV treatment and relatively high drug costs. Let's move on to the next slide. So before I go into the key market highlights, I just want to make a quick note on the guidelines. The WHO guidance on prevention, testing, and treatment are referenced across several guidelines. You can see snapshots of these guidelines released between 2015 to 2020, and the type of interventions highlighted across the guidelines on the right-hand side of the slide. The testing algorithm for HPV referenced mainly in the guidelines released in 2015 and 2017 remains fairly complex. It includes several tests and evaluation for the assessment for long-term treatment and monitoring of patients not indicated for HPV treatment to assess and evaluate disease progression. Notably, the new WHO HPV prevention of mother-to-child transmission guidelines, which focus on antiviral treatment prophylaxis in pregnant women, in addition to the expansion of hepatitis B birth dose vaccine, provide a step towards a public health approach. The guidelines recommend the use of hepatitis B e antigen rapid testing for pregnant women in places where viral load testing is not available to determine eligibility for tenofovir prophylaxis. And this could provide opportunities for decentralization of HPV testing and diagnosis. And the newest guidelines also provide opportunities for building upon the backbone of HIV and syphilis PMTCT programs to scale up testing and treatment among pregnant women to eliminate vertical transmission of HPV. Hopefully, future updates to HPV prevention, testing, and treatment guidelines expected within the next year, as Dr. Doherty mentioned, will continue to emphasize simplification and public health approaches. Moving on to the next slide. So just to touch on the HPV diagnostics market landscape, I'll speak to three key diagnostics: hepatitis B surface antigen tests, hepatitis B e antigen tests, and hepatitis B viral load tests. The surface antigen test is the diagnostic that is the entry point for the cascading of care. Fortunately, there are a number of high-quality surface antigen tests, 5 of which have WHO pre-qualification, including 3 RDTs and 2 lab-based ELISAs. Global prices for the surface antigen RDTs are generally comparable with other RDTs, below $1 per test. And you can see in the graph on the right-hand side of the slide that public programs in countries like India and Cambodia are procuring RDTs as low as 10 and 60 cents respectively. As I noted before, the use of e-antigen testing is recommended for pregnant women when HPV viral load testing is unavailable, and this could provide an opportunity for decentralization of diagnosis. However, there are market barriers to be overcome here. While both RDT and lab-based e-antigen tests are commercially available, there's currently no WHO pre-qualification process for e-antigen tests, and overall visibility of global e-antigen test pricing and product availability in the countries we work in is limited at this time. In terms of viral load testing, the landscape for HPV viral load tests is similar to that of HCV. HPV viral load testing is available on most of the platforms being used for HCV viral load, and the supplier viral load global pricing agreements that my colleague Emmy referenced earlier for HCV also include HPV as well. And this means that there is significant opportunity to integrate HPV viral load testing on platforms used for HCV and HIV viral load testing and to access better pricing. So now moving on to the HPV treatment market landscape. The WHO recommends the use of tenofovir or entecavir for the treatment of hepatitis B infection in all adults, adolescents, and children aged 12 years or older for whom antiviral therapy is indicated. Only entecavir is recommended for children aged 2 to 11 years. and both products are off patent globally. In terms of supply, tenofovir has been the mainstay for HIV treatment and has a broad supplier base of quality approved generics, with 6 generic suppliers being WHO pre-qualified for tenofovir. For entecavir, only 1 generic has received WHO pre-qualification. In terms of pricing, though tenofovir is commonly used as both an HBV and HIV treatment, the price paid by HBV programs and patients is often not at parity with the price accessed by HIV programs across the countries we work in. The median price of WHO pre-qualified generic tenofovir on the international market is lower than $32 US per year. However, you can see from the chart in the right-hand side of the slide that there's significant variability in the prices accessed by countries, with several countries reporting procuring tenofovir at significantly higher prices for HBV monoinfection. Countries such as Cambodia and Indonesia are paying more than $200 for a 1-year tenofovir course. While the country-specific drivers of price variation of TDF between HBV and HIV programs needs to be better understood, differences in factors like financing availability, procurement channels, and rollout of services could be contributing to this price variation. The other recommended HBV treatment, entecavir, is costlier than tenofovir. The price of tenofovir has been driven down over the past 2 decades due to its wide use in HIV treatment, while the market for entecavir has been much smaller, and hence there has been significantly less investment in the product. I'll move on to the next slide. So just to conclude this section, I said earlier that there is significant room for growth in the HBV market, but the good news is that some of this momentum has already started. Some countries have started to expand HBV testing and treatment by building on the foundation of their HCV programs. India, for example, has now expanded its HCV infrastructure to screen and treat patients for HBV. Similarly, Rwanda has scaled up its viral hepatitis HCV program to include HBV testing as well. Countries working towards the dual elimination of perinatal HIV and syphilis infection, like Cambodia, are also including elimination of mother-to-child HBV transmission within their programs as part of a triple elimination agenda. And this integration of screening and viral load testing of HBV within the antenatal care setting will support the expansion of HBV programs. There are also opportunities on the horizon for further product innovation and expansion for HBV. For example, point of care testing for HBV has the potential to broaden testing in low resource settings. However, more tests need to be ratified for clinical use by international regulatory bodies to enable uptake. Additionally, an integrated rapid diagnostics test for HIV, syphilis, and HBV could help improve screening coverage in the antenatal care setting. However, at the moment, no multiplex product, including HBV, is commercially available with WHO PQ, and countries will need to assess both the programmatic value add and considerations of introducing combo testing. And finally, new presentations of the hepatitis B birth dose vaccine and controlled temperature chain could increase coverage and access to the vaccine at a community level. I'm hoping we'll be able to continue to build out the HBV market intel and further dive into commodity price variations and bring more intel to the volumes in the next iteration of the market report, which currently is difficult in the absence of a public database for pricing and volumes for HBV commodities. With that, I'll pass back to Craig.
Thank you so much, Oriel. In the interest of time, I'll go straight into to round off this session, 2 country examples of success at using some of the strategies from the first market report last year. I want to turn first to Chukwemeka Agwacha from Chai, Nigeria, to give us a Nigerian example.
Thanks, Craig. So moving on to our country experiences, I'll be sharing, as Craig had mentioned, our Nigeria experience with focus on strategies employed to accelerate access to viral hepatitis molecular testing. Just to mention that Nigeria has a huge burden of viral hepatitis, an estimated 80 million persons clinically infected. So while we have seen this average national prevalence of HCV for 1.1%, regional variations do exist, like we've seen globally too. The same picture we have in the Nigerian context with some states like Nasarawa displaying double-digit seropositivity rates. So with this scenario of a huge burden, it was key that we needed to facilitate access to HCV services. So to kick off these conversations, we'll be looking at our early challenges. So coming into the Nigerian landscape, we had observed some notable challenges, which include high cost of testing, going from as much as $140 per test, mainly in the private sector, an amount really not affordable to the ordinary Nigerian, to the average Nigerian. In addition to this high cost of tests, we also had a situation where patients, like you saw in Nasarawa, had to travel as much as 850 kilometers to access this testing, and as such, leading to poor diagnosis and screening demand for HCV services. In addition to the high costs, patients also, we saw a case where healthcare workers lack the capacity to effectively manage infected patients. I recall that before now, we had the specialists being responsible for treating hepatitis C, and in the Nigerian context, we had just about an average of 2 or 3 specialist doctors per state. So with that, there was a huge gap in the supply space for healthcare workers. So to address these gaps and drive uptake to diagnostic services, we employed a myriad of strategies, but we'll be sharing 4 key strategies which led to transformational impacts in our country. So starting with the stakeholder engagements, the major stakeholder is the Federal Ministry of Health, or the Ministry of Health in different states as well. Others include the gastroenterologists, and they also have focal persons from the facilities. But just to mention that one key criteria in selection of stakeholders have to do with those relevant to the care cascade, and also have level of high influence to lead these conversations. And what you have noticed is that these stakeholders should have an idea of the program direction to be able to have valuable conversations. Then considering that most companies usually look at volume demand, as we have talked about procurement in our earlier conversations. So it was important to employ strategies to expand access to HCV services in our context. And through the public health approach, where we've seen simplified therapy approach to treatment of HCV, there was a need to decentralize care, training the non-specialist physicians to be able to manage this disease, thereby driving case finding and also treatment. So what we have now is not about 15 sites providing HCV viral load testing. And most of these sites are actually in the hypothesis I mentioned earlier, the hypothesis of Nasarawa. Now, moving from the expansion of testing sites, another approach was having that constantly gathering that market intel to understand the recent trends within the global landscape. So, like we have shared in this report, we've seen other countries how they've been able to access low pricing. So having this intel and domesticating this to the country context was quite key to market shape and drive down prices, not to mention understanding, having that visibility across the value chain, which gives you an opportunity to optimize the markups and bridge the gaps from Ex Works to cost facility. So having this done in the country, we're able to drive down the cost. But we took a step further to also negotiate at the facility level. Coming into this space, we saw a lot of commodities have like about 30% markups. We're able to advocate for just about 10% markup just to cover the operational cost for the commodities. And considering that in the absence of that financing for the program, patients being out of pocket, it was important to come up with low prices to accelerate uptake of the services. So just to give you an example how we're able to walk through these approaches to achieve pricing reductions. So we recall that in 2019, we had Roche expand the global access pricing, which was usually limited to the HIV program to cover viral hepatitis. So having this information, as I mentioned, market intel from the global space, we quickly engaged with the stakeholders in country to understand how we could best maximize this opportunity. And necessary conversations with the key stakeholders driving these conversations, the Ministry of Health, facility focal persons were able to identify other cost components along the value chain where we had some markups to advocate for low pricing. And with that approach, we are able to achieve a 40% reduction in cost to test. And currently we have not less than 5 sites implementing the gap pricing in country. And armed with this approach and information, we're able to expand or duplicate these efforts around the GeneXpert, which also led to a 20% price reduction. So with this, we have seen low pricing, we've seen increased patient uptake of the services, and also seen in the case of one of our states, we've seen where we need to prioritize funds to procure, to advocate for more commodity procurement. So this just summarizes, in our Nigerian space, how we've been able to expand access to viral load testing, and also what we have achieved as well in this space. So I pass back to Craig. Conversation. Thanks.
Thank you so much, Chukwemeka. I want to turn to Caroline Thomas now from Yayasan Peduli Hati Bangsa in Indonesia to talk about the advocacy work that resulted in some pretty incredible price reductions for DEAs in Indonesia. Over to you, Caroline.
Thank you, Craig. So, thank you, everyone. My name is Caroline. I'm from Peduli Hati Bangsa, Indonesia. As of 2021, we have 6 registered sofosbuvir, all generic registration, and also we have 3 daclastavir registered in Indonesia. So in the next slide, we can see that the price of the sofosbuvir and the daclastavir is also reduced. Sorry, next slide, please. Okay, in 2017, the price of sofosbuvir is around $166. Sorry, before that. Before the slide before, one slide before. Okay, $166. In 2019, we don't have we have a slight change in the price, which is 156. Also in 2020, but in 2021, the price is reduced to only $22 per bottle. So it has to be tripled for people who are non-cirrhosis and 6 times more if we are counting for people who are with cirrhosis cases. So before in 2020, the daclastavir is registered in the national e-catalog, and the prices was quite low at that time. It's $13 for the 60 milligrams and $9 for the 30 milligrams. So before 2020, we are using the daclastavir from the Quick Start program of CHAI. That is why there was differences in the registration of sofosbuvir and daclastavir in the e-catalog. And also before 2020, we can choose to either buy from the combination of both combination or use the Quick Start program as part of the government distribution. And the out-of-pocket price for non-cirrhosis people and people with no comorbidity with HIV is around 1.7 million rupiah, or approximately $400 per month. So for PL-HIV who needs dosage adjustment, of course, the price is higher. This is largely is a result. The price reduction is largely a result of the demand from the community, and also by informing the government about the comparison of prices across countries in the same region. Other than that, competition is also the key to reduction of price. As you can see, from 2017 to 2020, we have a lot of generics company registered in Indonesia. Our part as a society, as the community member, of course, we talk to the government as well as talking to the the local partner of the generic company in Indonesia. So as of 2020, the number of DAA as part of the government program can only cover 5,500 patients. So the question is it enough? How big is the burden of hepatitis C in Indonesia? As we can see in the next slide, we can see that in 2018 to 2019, we did a study on the epidemiological and cost modeling for eliminating hepatitis C in Indonesia. And here is the result. If we are using, we have 4 scenarios, which is elimination by 2030. And if we look at the worst case scenario, which is eliminating hepatitis C gradually in 2040, we have to at least the number of people treated in 2029 by treating 240,000 people. As I said before, currently we are only treating 5,500 to 6,000 people per year. So we are still far from the target of elimination. In terms of advocacy, along with the prices report and the comparison, the government, of course, will be asking what is the benefit for them for the government to reduce the price and to invest in hepatitis C program in Indonesia. Through the study, we can say that as for the national saving, reduction of DAA to $150 and viral load prices to $40 could reduce the total program cost by 68% to the national saving of 1.7 billion in total. So that is the worst case scenario. Of course, if the government invests more, they will gain. In terms of the elimination, under any elimination scenarios, as you can see in the next slide, yes, there will be less than 3,000 new infections by 2040. That is also using the worst case scenario, while the current number of new infection per year is 85,000 people newly infected per year. So using any elimination scenarios, we are actually reducing the number of new infections. So the key messages here is, the first one is to allow competition, and the second one is because the competition will lower the price and also increase the coverage. So we are still waiting for the government. Now we are reaching the lower price, but we are still waiting for the increased coverage, and we are still doing advocacy for the increased coverage. As we all know that Indonesia is a really large country, so increasing coverage will increase the number of people, will increase chances of elimination. Other than that, the key messages here is for the community to actively participating in monitoring government program, and also for us to address bottlenecks will be easier is if we have references such as this market report. So from our experiences, using such a report enables us to compare prices across regions as well as across countries in the same region. You can imagine countries in the same region, and if we're having similar GNI, but we procured the DAA at a very different price, we can always question the government, especially if we are the ones who procured it at a higher price. Other than that, price and procurement transparency is very important, and also doing an investment case study will also help us to do the advocacy so that the government can do a better program for the national. Thank you so much. Back to you, Craig.
Thank you so much, Caroline and Chukwemeka, for really showing us how civil society advocacy can be driven by market intelligence, and being armed with the data, the information, you can really achieve some remarkable success in terms of driving down prices, but ultimately in terms of treating and curing more people of hepatitis C in the drive towards elimination. We have a few minutes left, which is remarkable considering all the information that was presented by the various speakers. Thank you to all of you. I want to turn to Sean Regan, who's going to walk us through some of the questions and answers that were posed online. Over to you, Sean.
Thanks, Craig. And just to note, thank you for everyone who asked a question. We are busy trying to respond to them in the chat, and may respond to a few offline if we can't get to them. But let's go ahead and throw a few live to our panelists. Emmy, let's start with you on the diagnostics front. There's a few questions here on Cepheid pricing. There's also a question about Hologic and their status in the HCV and HBV market, and then a question on e-antigen quality. So if you could answer those, then we'll move on to a few more.
Great, thank you, Sean, and thank you all for the questions and comments. We are aware of the MSF and TAG campaigns for the $5 cartridge for Cepheid, which extends to all cartridges, not just hepatitis C and hepatitis B, but also importantly, HIV, tuberculosis, and other disease programs. So thank you for sharing the materials. Cepheid is an important supplier for hepatitis viral loads, given their footprint from tuberculosis, which we're all aware of, and the opportunity for integration on the Gene Expert machines. As well, they're one of the few suppliers that offer point of care testing with the machine, in addition to Gene Drive, which recently became pre-qualified this year. So further pricing reductions from suppliers like Cepheid would improve access and hopefully enable more countries to scale up diagnosis by allowing budgets to go further, as we know that often financing can be a constraint. When thinking about Hologic, then Hologic has confirmed that they will stay in the market. So I'm not aware of them stopping HBV or HCV viral load. In general, as we discussed, we believe that viral hepatitis is a growing market of interest to suppliers. So believe that this should be of increasing interest to suppliers. And then lastly, on the hepatitis E antigen, thank you. So the report does go through the different assays that have FDA approval for lab-based immunoassays. We do know that RDTs have had variable results to date, though these could also be trialed in countries. For example, there was a recent publication from ANRS in Cambodia showing that an HBe antigen RDT performed comparably to viral load when used in an algorithm with ALT to stratify pregnant women for tenofovir use. So all to say that the WHO does not have a pre-qualification list for HBe antigen, though increasing focus from all partners in the community could allow us to advance this diagnostic, which may be more affordable and may be more available than HBV viral load in the prevention of mother-to-child transmission. Thank you.
Thanks, Emmy. Appreciate it. We have a few minutes left, and there's a question in the chat from Greg about the room for further market shaping opportunities, sort of driven by strong forecasting and data at the country level and being able to pool procurement. Meg, I believe we still have you if you're able to go on mute here. You mentioned the importance of strengthening country level data and the importance of strengthening M&E. Is there anything you can say for partners like CHAI or others who are on the call who can help over the course of the next strategy to really strengthen those efforts? Are there any practical items that partners like us can take on to support those efforts? Or should we come back to that after the next strategy is published and we have a bit more clarity?
I'm not sure. Meg texted that she may have to run off, but I think Fumi Leshy, who coordinates the hepatitis program at WHO, sorry, I think is on the line. Fumi, are you able to speak to that question?
Craig, we may have to promote her to a panelist, but let me throw it to you, just the question. I mean, and do you agree with my statement that we can actually, there is more room to do market shaping here in the DAA space? I mean, it's a pretty broad question, but is there broad agreement amongst us here at CHAI that we can get pricing down further with market shaping interventions like pool procurement?
Yeah, I mean, I think that there are very few countries at the moment who are forecasting adequately.
Right.
Pretty much those ones we identified as having robust adult programs like Georgia, Ukraine, Rwanda, India, Pakistan, Egypt, Mongolia. And we're not going to see that kind of useful forecasting data from countries until there is an expansion of programs, until there is more pooled procurement. A lot of countries are still buying site by site versus at the national level. And certainly there is some way to go in terms of price reductions, but I think prices fell so quickly, so fast, because of a few countries scaling up quickly, that we're likely not to see any more significant price reductions until volumes increased and until suppliers can see more reliable forecasting data coming out of countries.
Right. Great. Dr. Lecce, I saw we promoted you to a panelist. Is there anything you'd like to comment on top of what Craig just said, or on the question of data and understanding what the situation is at the country level a little bit better as we move forward?
Thank you. Can you hear me?
Yes.
Okay,
please go ahead.
Fantastic. Thank you very much and congratulations. Yes, there is a huge data gap in many parts of the world, but for the 2021 progress report, 130 countries reported data in the global reporting system for viral hepatitis. And currently we're working to ensure that hepatitis B indicators for PMTCT are reported in the GAM that reports for HIV and syphilis, and that will help us get more data recording. Currently, we have a data collaborative with some global and regional partners to try and build national capacity for data reporting. And we hope to have partners on the field, partner data, partners like CHAI, especially in the countries where you are, because we know that you have strong data. And I think CHAI is part of the data collaborative to support countries. Please correct me if I'm wrong. So towards hepatitis elimination and the interim guidance, data is important to document progress. So it becomes critical that countries develop the appropriate data systems. I don't know if that responded to the question.
Thank you, Doctor. No, that's great to hear, and I appreciate that. That's great, and congratulations again on that report. It's great to see the updated numbers and progress. Craig, let me throw it back to you. We're going over time, so why don't I throw it back to you and we'll wrap up.
Yeah, thank you very much, Sean, and thank you to everybody. I don't want to keep people over any longer. We're 2 minutes over, and apologies that there weren't more time for questions, but please do note that if your question wasn't answered, the team will try to answer it individually following the webinar. I want to thank all our panelists, in particular Dr. Doherty from WHO for joining us today, and Caroline Thomas from Indonesia for joining us today, from Yayasan Peduli Hati Bangsa, and for all of you for taking the time out of your day to listen to this webinar. We hope that the report you'll find useful in your day-to-day work, whatever that is, across different stakeholders, and we'll continue to try to document market intelligence over the coming years as we all work together towards eliminating viral hepatitis as a public health threat. I see, Meg, you've come on video, and maybe you'd like to give a final goodbye. No? Okay.
Just
all
to
right.
say thank you.
Thank you so much. Thanks to everyone, and have a great day, evening, wherever you are. Stay safe and be well. Thanks again.